Hi, everybody, and welcome to our endocrine system lecture, part 2. So we are going to talk about the posterior pituitary gland to start with, and then we'll dive into some of the other endocrine organs later on. So posterior pituitary gland is unique because it actually doesn't produce any hormones itself. Rather, it is responsible for the storage of the hormones produced by the hypothalamus. So there are two main hormones that are stored within the posterior pituitary gland, and they are known as antidiuretic hormone, and the second one is oxytocin. Antidiuretic hormone, also known as vasopressin or ADH for shorthand. So we're going to take a look at the path that these hormones take for the purpose of storage from the hypothalamus. And then we're also going to take a look at what they actually do in our body and how fluctuation in their levels can have an effect on the functions of the body. So let's go ahead and take a look at our first path of the hormones traveling from hypothalamus to the posterior pituitary gland. So within the hypothalamus, we have these two nuclei. In this picture, one is depicted as green and the other one as blue. So paraventricular nucleus is responsible for producing the hormone oxytocin, and supraoptic nucleus is responsible for production of your ADH or vasopressin. So the way these work is, and again, looking at the structure, these are basically neurons. You have the cell body and the dendrites up here inside the nuclei, and then the really long axons that basically extend from the hypothalamus down through the infundibulum and eventually into the posterior pituitary gland. So again, remember that at the end of the axons, you have your axon terminals, and the axon terminals is where you will be storing your hormones, ADH or oxytocin, depending on their connection to the hypothalamus. So when hypothalamus notices a change or a need for one of these two hormones, these neurons are basically going to send an electrical impulse down through their axon, and they cause the release of the hormones from their axon terminals, which are located again as these yellow dots at the end. Now, these hormones basically now get picked up by what we identified as the inferior hypophyseal artery and capillary and vein, and gets transported to the body, to the target tissue. So the network system that you see in the anterior pituitary gland, which was the primary capillary plexus, your portal vein, and then your secondary capillary plexus, are more complex when it compared to the simple extension of the neuron from the hypothalamus to the posterior pituitary gland. So do keep in mind that there are main structural differences when we compare anterior to posterior pituitary gland. So what is the function of antidiuretic hormone? Antidiuretic hormone is a hormone that is targeting the kidney tubules or kidney tubes when there is a shortage of water in our body. So simply put, when the person is dehydrated. So within the kidneys, you have these microscopic structures called nephrons. And nephrons have these tubes, and I'm just going to kind of simplify a nephron for you guys. It's just basically something similar to this. Here is where the filtration happens, and here is when you reabsorb anything that you need. So these are basically the tubular network within the nephron that are located within your kidney. Now, the end portion of this tube, which is right here, is shorthand to DCT, but the full name is distal convoluted tubules, or again, shorthand DCT. If you continue DCT, you open it up to this thicker tube, which is here called the collecting duct. So collecting duct, and as the name implies, it's basically gonna collect. So within the distal tubules and your collecting ducts, your body is basically notices that, let's say you're getting rid of too much water. So a signal comes in from your hypothalamus, the ADH gets released from the posterior pituitary gland. That ADH reaches your DCT and the collecting duct, and it's going to take the water that would have been urine and would have been excreted from the body and reabsorb that body back into the system. So if you're dehydrated, you don't want your body to continue losing water as part of urine. You want to take as much as water away from the urine and take it back into your system. ADH allows you to do that. So it increases water reabsorption, and as a result creates a very concentrated urine sample. Now, typically when we describe it, when you have a hypersecretion of ADH, you're dealing with a condition called syndrome of inappropriate ADH secretion. It's a mouthful. And basically that means your body has a high level of ADH. And as a result, is going to reabsorb a significantly higher level of water from your renal tubules. Consequently, that extra water is going to end up in your blood and in your tissue. So you're going to have an increase in blood volume. And that increase in blood volume is going to put higher pressure on your blood vessel, causing hypertension, which is simply means high blood pressure. You also are impaired in terms of losing extra water. So because ADH keeps telling your body to hold on to the water, your body does that, and therefore excretion or removal of that extra water become impaired. Now we have a specific type of diabetes called diabetes insipidus. This is a type of diabetes that has to do with the level of ADH. When you have a very low level of ADH in your system, so in another sense, hyposecretion of ADH, as a result of either your hypothalamus not producing enough ADH, or your posterior pituitary is damaged as a result of brain trauma or tumor. Regardless, your ADH will drop, and consequently your body is unable to reabsorb the necessary water. So you are going to remove an excessive amount of water through urination. This type of diabetes could also be as a result of damage to the kidney. So as a result, again, the description that I gave you previously, that process cannot effectively happen, and water just gets removed from your system at a very high level. The reason that diabetes insipidus could happen is either could be a genetic mutation, visible only in males. It could be a result of taking specific type of drugs. It can be as a result of infection within your kidney, or very high level of calcium, which basically causes damage to the tubules of the kidney. And that process called hypercalcemia. Now, regardless of this, what is the reason for diabetes insipidus? People will have basically this feeling of severe thirst because their body is losing significant amount of water. They are people, and I would say most of the cases, if you are dealing with this condition, you will be okay if you have sufficient water intake to basically off balance the water you're losing. But there are cases, severe cases of diabetes insipidus, where the person basically loses up to 10 liters of water every day, and that is huge amount of water. And if it's not treated, then the person will die as a result of dehydration. Now, the second hormone that gets released from the posterior pituitary gland is the oxytocin hormone. So oxytocin hormone is extremely important in terms of female and during childbirth. So the oxytocin is the only hormone that works in a positive feedback, which basically means when you have a specific amount of oxytocin in your system, in certain cases, that level actually stimulates the release of higher levels of oxytocin from the posterior pituitary gland. And you kind of have that spiral of oxytocin level spiking during childbirth. So what is the oxytocin function? It actually causes muscle contraction. The higher the level of the oxytocin, the stronger the muscle contraction will be. And in this case, the target would be the uterine muscles. These are smooth muscles. So basically, as the woman is undergoing childbirth, their contraction become more severe because the oxytocin level increases. When the child is born, the oxytocin level stays high, but not as high as it would have been during childbirth. The main goal of that would be to target the mammary tissues to initiate milk ejection, basically make sure the baby has food, and that level remains high during the time of breastfeeding. In case of both male and female, we have oxytocin connection to what we consider a feeling of trust or love. So a lot of people refer to oxytocin as the love hormone. It's the hormone that elevates when you feel secure or safe with somebody, when you get that kind of good feeling at the stomach, where you are happy to be with somebody. That's usually as a result of elevated oxytocin. So a lot of this connection happens during the first year or so of baby's development, specifically the first few months. So that's why if you have been around new mothers or you are a new mother, they encourage many things like skin-to-skin contact. They really push for breastfeeding because both of these causes an increase in the oxytocin level in both the child and the mother, and that create that kind of connection or bond that is necessary for a healthy growth of the child. Okay, the next gland we're going to talk about, which is a more complex one, is the thyroid gland. The thyroid gland, we talked about the location before, but I'm just going to show it to you. So here is your thyroid gland. To kind of orient you first, this is your trachea. This tube right here you see is your trachea. This is the aortic arch, which basically means that it's very close to your heart. It's superior to your heart. This is the hyoid bone that is located right underneath your chin. And that's your thyroid cartilage, which is basically protecting your vocal cords. So this is a bilobed gland. So you have two lobes that are connected by a connection point called isthmus. And it is the largest pure endocrine organ that we have in our body. Now, there are two main hormones that are produced by the thyroid hormone. The first one is, thyroid gland. The first one is your thyroid hormones. There are two categories. One considered to be T3 and the other one is T4. And both of these are extremely important for helping you maintain your metabolism and carry out the activities within your body. They also play a major role in body temperature. Calcitonin, on the other hand, is identified as the humoral hormone or stimulation where it controls the levels of calcium within your body when it is elevated. So let's take a look at the thyroid hormone first. So thyroid hormones, as I mentioned, there are two categories. One is called the thyroxine or T4, and the other one is thyroiodothyronine or T3. Now, their location is within a specific space called follicular space within the thyroid gland, I should say the place for the production. And the production of this hormone is it's a process, it's a complex process, and it requires three main components. A protein called thyroglobulin, an amino acid called tyrosine, and the presence of iodide in your diet, which typically comes from iodine salt or iodinized salt. So to make these thyroid hormone, these T4 and T3 hormones, this is the process they undergo. So first, we need to take the iodide that comes from your diet and make it an organic molecule through a process called organification. Now, I'm not going to go into the detail about how this happens. That's, again, biochemistry. But as far as you understand, organification basically means changing an inorganic molecule to an organic version. The next thing we do is we're going to take your iodine, which is already organic, and combine that with your amino acid tyrosine. Now, the combination, combining or the binding process is called iodination. So the way you actually combine tyrosine and iodine makes two types of molecules. One is diionidated tyrosine, which is shorthand to DIT. And the second one is monoionidated tyrosine, or MIT. If you guys don't recall, di means two, which means there are two iodine molecules involved, and mono implies one. Now, the last process with completing the synthesizing of the thyroid hormone is coupling reaction, where you combine either your DIT or MIT with your protein thyroglobulin. So if you take two of your DITs and combine it with your thyroglobulin, you get your T4. And if you take one DIT, one MIT, and your thyroglobulin, you get your T3 or your thyroxine. So it is important for you guys to recall that the components that make your two thyroid hormones are the same. It's just how you couple them together, which forms the final product. Here is another depiction of what that looks like in terms of the chain reaction you expect to see connecting the hypothalamus to your thyroid gland. So you have the hypothalamus releasing your thyroid releasing hormone that targets your anterior pituitary gland. Anterior pituitary gland releases thyroid stimulating hormone into your blood, which transports to the thyroid gland, and thyroid gland produces T3 and T4, which basically controls your metabolism and your body temperature. Now, it is extremely important to keep the levels of these thyroid hormones same or within ideal range. If there is a fluctuation in terms of both hypersecretion or hyposecretion, you will see major changes within the body. Now, hypersecretion, which is also known as hyperthyroidism, is very similar to the effect of what we identify as a Graves' disease. Graves' disease is when you have antibodies in your body mimicking the TSH, which basically means there is an elevated levels of TSH and therefore an elevated levels of thyroid hormone. Now, regardless if this is as a result of Graves' disease or you actually have an elevated TSH, we will see similar symptoms. So the symptoms would be rapid irregular heartbeat, again, part of metabolism. That process is called tachycardia. You will have significant weight loss because your metabolism is much faster. Because your metabolism is faster, you burn through more calories and therefore you are continuously hungry. You may be seeing symptoms of nervousness. A lot of time you see a decrease in your muscle mass because your body starts to use muscle as a source of energy. You may have, if you're a female, you can see fluctuation or changes in the menstrual cycle. Your digestive system might be overworked, so you will see signs of diarrhea. Your nervous system might be affected, causing muscle to tremble. You may have, and again, you may not have all these symptoms, but these are very common if you have hypersecretion. Your blood pressure might be elevated, which is basically increasing your systolic blood pressure, and you may or may not have an enlarged thyroid. Typically, if you are treating a hypersecretion or hypothyroidism, you do that with anti-thyroid medication, or you can do it by introducing radioactive iodine, which is going to lower the production of the thyroid hormone, both T3 and T4. The opposite is also can cause severe changes. In this case, you can have severe changes if it happens in children, typically as a result of mother being iodine deficient during pregnancy. So the child being born may have growth retardation. They may also have developmental delay. The condition called cretinism, and again, it's visible in children. In adults, if you have low levels of TSH, which causes the drop in levels of thyroid hormone, you have myxedemia, which is basically opposite symptoms. I put that in quote or take it with a grain of salt. Opposite to what we saw for hyperthyroidism. So you will see feeling of cold because your metabolism has slowed down significantly. In most cases, the person will have an increase in weight. Their appetite might be gone. Their digestive system slows down, make them more susceptible to constipation. Their heart rate might drop. Their may have muscle weakness. Their, again, menstrual cycle might be affected in females. There might be a decrease in their body hair. And again, the most common one would have been also a slowing of the heart or bradycardia. So if you have symptoms that are like this, again, typically this is a result of TSH level being low, which causes the thyroid hormone level to be low. So I want you to be cautious when I am comparing what I've told you about hyperthyroidism and hypothyroidism, and compare that to a condition called goiter, which is the next slide for us. So goiter is when you have an enlarged, or I guess way to diagnose goiter is when you have an enlarged protruding thyroid which is basically, as you can see in the image, it's really visible in the neck region. Typically, if you have such a large thyroid, you have extremely difficult time swallowing or talking or sometimes breathing, because it basically, the thyroid gland is going to squeeze both the trachea as the esophagus. Now, goiter is not a result of low production of TRH or TSH. It actually relates to low level of iodine in the diet. So remember, iodine is necessary for production of both thyroid hormones. So if you have low levels of thyroid hormones, which was observed in 1920, because you have low levels of iodine in your system, then your goiter start to get enlarged. Easy way to fix it, literally start to take food that are rich in iodine, or just take, the easiest way is take iodized salt, which is most of the salt that we have nowadays, which limits the chance of developing goiter in advanced countries. So one thing that distinguishes goiter from hyperthyroidism, hypothyroidism, is the levels of TRH and levels of TSH. So let me clarify. If you have hypothyroidism, which is here, hypothyroidism, if you look at the sequence, which is TRH, TSH, and TH, TRH level is probably low. TSH is also low because you're not stimulating. And if TSH is low, then your TH or your thyroid hormone will also be low. So if you have a pattern of low levels for both your TRH, TSH, and your TH, that's identified as hyposecretion or hypothyroidism. However, if you have, on the other hand, you have an elevated levels of TRH and TSH, basically your body wants to produce higher levels of TH or thyroid hormone, but it doesn't have the capacity to do that, then you'll see, and again, elevated levels of TRH and elevated levels of TSH, but low levels of TH. And that's how you can actually diagnose a person with goiter versus a hypothyroidism. Please do keep in mind when you assess that, it's really easy to identify which of the two conditions we're dealing with by a simple blood test, because you can measure both the TSH as well as the TH in the bloodstream. Now, the last thing that we're going to talk about in this PowerPoint is your calcitonin, which is the second hormone produced by your thyroid gland. Now, for us to go over that, I wanted to revisit the homeostatic feedback loop that was described in detail in Bio 250 or your first semester course, but just to kind of review this and making sure everybody is on the same page. Homeostasis, as I mentioned earlier, is basically maintaining an internal environment. That means most of your ions, your body temperature, your glucose, your heart rate, your blood pressure, all of these are maintained within a set number or set range, which is called a set point. Anytime you deviate from that, either going above or below that acceptable range, then you activate what we identified as a homeostatic feedback loop. It starts with a stimulation, which is again increased or decreased away from that acceptable range. That a stimulation will be noticed by a sensor, which is basically monitoring or looking out for changes. Sensor usually reports to a higher power, which is typically your endocrine system or your nervous system. And that's identified as your integrator. The quote unquote big boss makes a decision of how to resolve the problem and create a response called an output. That output can be an electrical signal or a hormone release from the endocrine system. The output is going to target a specific tissues in your body or organs within your body, and those organs or tissues will be identified as your effector. The changes that are going to happen as a result of those outputs, the changes the effectors are going to take are called response. And when you take all of these changes that have occurred, all of these responses that have occurred, your goal is to return everything back to homeostasis, and we call that your result, your final goal. So when we're talking about your thyroid gland, and when we're talking about calcitonin, we have the same process described here that I'm gonna go over with you. So here is what we're describing. When there is a decrease in your calcium level, we have the parathyroid hormone kicking in or activating. If you have an increase in your blood calcium above the number 11 milligram per deciliter, then you have calcitonin being released from your thyroid gland. So in this case, if you're kind of assigning what I've just mentioned to you guys in terms of your homeostatic feedback loop, this number right here, 11 milligram per deciliter, this number is your, what we identify as our set point. If you are going above that, so increase above 11 milligram per deciliter, sorry, I ran out of room, that would be your stimulus. So in this case, the sensor that is monitoring and also creating the final response, which is basically we're talking about your sensor and your integrator. They're the same structure. And these are identified as parafollicular cells or C cells that are located within your thyroid gland. So in this case, if I was asking you what is the thyroid gland in this system, it is both your sensor as well as your integrator. Now, the sensor integrator notices the change, figures out the problem, and sends an output. So this calcitonin that we have here, calcitonin would be my output. Now, what are my effectors? What are the targets that calcitonin is going to send message to? First one is your bone. That's your effector. Second one is your intestines. And third one is your kidneys. Now, you have a high level of calcium, which means you really don't want to bring in additional calcium into your blood. So how do you do that? And I'm going to start on the right-hand side with your kidney. So your body gets rid of extra ions, including calcium, by literally excreting it as part of urine. So if you have extra calcium, your kidney says, okay, I'm going to get rid of extra calcium. So you're going to have calcium loss to your kidneys or your urinary system. So again, calcium excreted. So these would be your actual response, right? These are your effectors and this is your response. So calcium gets excreted. Now at the same time, your kidney is also produce what we identify as, or I should say, produces less of what we identify as calcitriol. And I'll talk about why that is important. When there is less calcitriol, and also there is a presence of calcitonin, your intestines says, I am not going to absorb as much calcium from my digestive system. So that calcium that came from your food or from that calcium pill that you've taken is not going to be absorbed into your bloodstream because your body knows that you do not need that. So look at here, you said calcium absorption slows down within your small intestine. Last thing that happens is your body says, well, I have extra calcium. Can I actually store that calcium? And the answer would be yes. So in such scenarios, your calcitonin is going to have an effect on cells called osteoblasts. And hopefully you guys remember this from the previous semester. Osteoblast is going to help us take that extra calcium and store it inside your bone. At the same time, you want to limit or inhibit your bone breakdown that causes that calcium to be released into your blood. So you already have enough calcium in your blood. You don't want more calcium to be released from bones. So the activity of cells called osteoclasts, which their job is to literally break down your bone and release calcium, is going to be inhibited. So you're basically saying to your bones, start adding calcium to my bones, and at the same time, stop breaking down my bones. So combining this together, basically lowering the calcium absorption in the intestine, increasing the excretion of the calcium through your kidneys, and also adding calcium to your bone and slowing or stopping calcium release from the bone, taken all together, will cause your calcium level to go back down to normal or back to its own homeostatic feedback, which is, homeostasis, which is basically your result. Now, please do note that when the calcium level is back to normal, you don't want this system to continue happening. So you activate what we identify as a negative feedback loop, where you, through that process, you stop the release of calcitonin, so this whole system shuts down. So that's a way for us to help you to maintain your calcium level if it is elevated. In the next part of the endocrine system lecture, I will discuss with you what is the function of parathyroid gland when there is low levels of calcium in the bloodstream.